Imagine a plumber comes to your house and finds a massively rusted, like a 90% blocked pipe right under your sink.
Right, you'd panic.
Yeah, exactly. Your immediate instinct says you have to replace it right then and there. You cut it out, put a new one in. But what if that pipe is actually inside your brain?
Well, that's where things get really complicated.
Right, because modern medicine has recently figured out that, at least in certain cases, the plumber's snake might actually be deadlier than the clog itself.
It completely flips our whole, intuitive understanding of how to fix a physical problem. I mean, we are just so conditioned to think that a mechanical blockage obviously requires a mechanical
A
solution.
clog needs unclogging.
Exactly. But when you're dealing with the incredibly fragile architecture of the human vascular system, especially in the brain, rushing in with a stent or a scalpel can sometimes trigger the exact catastrophe you're trying to prevent.
Wow. So, if you are listening to this, you likely already know that an ischemic stroke or a TIA, a transient ischemic attack, is a life-altering emergency.
Absolutely.
But what we are looking at today is the complete paradigm shift in what happens next. We are taking a custom-tailored deep dive into a really comprehensive guide by Dr. Ashley M. Wabnitz on the management of large artery atherosclerosis.
Yeah, it's a fantastic paper.
It really is. Our mission today is to unpack how doctors basically have to act as both detectives and engineers, to keep blood flowing to the brain without causing further damage.
And to really understand the stakes here, we have to look at what large artery atherosclerosis actually is. It's essentially this disease where plaque builds up in the major vessels of the neck and the brain.
So it's like a slow buildup of rust.
Right. The inner lining of the artery, the endothelium, gets damaged over time, usually by things like high blood pressure or smoking.
Bad habits, mostly.
Yeah. And then cholesterol slips into that damaged wall, oxidizes, and triggers this whole inflammatory response. The body tries to heal it, but instead it just creates a fatty streak that hardens into a fibrous, calcified plaque.
Which obviously narrows the vessel, restricting the blood flow.
Exactly. And for patients who have already had a stroke because of this, well, the risk of a recurrent strike is just incredibly high.
So the first hurdle seems to be just finding the plaque. Like if someone comes into the ER with stroke symptoms, my assumption is that the immediate priority is scanning the brain and the neck.
Yep, you have to get a visual.
You find a narrowed artery on the scan, you map the clog, and boom, you found your culprit.
Well, you certainly find a clog, but finding just any narrowed artery does not mean you have found the actual narrowed artery responsible for the stroke.
Wait, really?
Yeah, the immediate step in the ER is non-invasive vessel imaging, typically a CT angiography or a CTA.
Because it's fast.
Right, it's incredibly fast, and it gives us an immediate roadmap. We also frequently use carotid duplex ultrasound because, well, it's highly cost-effective and really excellent for visualizing the arteries in the neck.
Okay, that makes sense.
But ultrasound has a critical blind spot. It simply cannot see past the skull.
Oh, right. The bone gets in the way.
Exactly. So it can't adequately evaluate the intracranial vessels, the arteries deep inside the brain, and it really struggles to screen the posterior circulation at the back of the head.
So if a patient might require surgical intervention, an ultrasound just isn't going to cut it. You need a CTA or an MRA, magnetic resonance angiography, to get that complete high-definition picture.
Precisely. You need the full map.
But going back to pinpointing the culprit, you mentioned earlier that a scan might show a severe blockage, but it might not be the cause of the stroke.
Right.
That suggests atherosclerosis is a systemic issue, not just an isolated one.
Oh, absolutely. That is the defining characteristic of the disease. A patient with plaque buildup in one artery almost certainly has plaque developing throughout their entire vascular system.
Right.
So, you might do a CTA and find a severely narrowed artery on the left side of the patient's neck. But if their stroke symptoms indicate damage in the right hemisphere of the brain,
then the left-sided blockage is completely unrelated.
Exactly. However severe it looks, it is entirely asymptomatic at that moment. It's not the culprit lesion.
It feels exactly like diagnosing city plumbing.
Yeah.
If there's water pouring through the ceiling of your kitchen and the plumber goes into the guest bathroom and finds a rusted, leaking pipe under the sink.
Fixing the bathroom sink does absolutely nothing for the flooded kitchen.
Right. The stroke, or TIA, must be strictly localized to the specific vascular territory fed by that exact narrowed vessel. Otherwise, you risk performing high-stakes medical interventions on the wrong pipe.
And pinpointing that symptomatic lesion dictates the entire trajectory of the treatment plan. I mean, you really have to prove causality.
Makes sense.
Once the culprit vessel is identified and the territory is matched, well, then the focus shifts to stabilization.
And this is where the sources point to a statistic that is genuinely hard to process.
Yeah, it's a rough one.
Once the detective work is done, the immediate step isn't rushing to the operating room. It is radical risk factor management. But in major clinical trials looking at these patients, less than 20% had optimal risk factor control at baseline.
Less than 1 in 5.
Right. If these targets are the foundation of preventing a second stroke, it just seems wild that over 80% of patients are completely missing the mark.
I mean, it really speaks to how incredibly demanding optimal management actually is. We are not talking about your standard everyday health guidelines here.
I'm talking extremes.
Exactly. We are aiming for highly aggressive physiological targets. Take cholesterol, for example. The sources heavily emphasize this landmark trial called Treat Stroke to Target.
Okay, what do they do differently?
Well, for years, the approach to managing lipids in stroke patients was somewhat generalized, but this trial tested a highly specific, very aggressive goal. They pushed LDL, the bad cholesterol, down to less than 70 milligrams per deciliter.
Less than 70, which is significantly lower than a standard healthy target.
Vastly lower. And the trial proved that hitting an LDL below 70 significantly lowers the risk of major cardiovascular events.
How much of a drop?
The risk dropped from 10.9% down to 8.5%, and that's compared to patients who were kept at a looser target of like 90 to 110.
Oh, wow. That's a real tangible benefit.
It is. But achieving that drop requires treating the human vascular system like a finely tuned machine. I mean, you cannot hit an LDL of 70 just by cutting back on red meat and butter.
It requires high-intensity statins, right?
Yeah.
Like atorvastatin at 80 milligrams.
Exactly.
And the sources say if the maximum dose of a statin doesn't push the LDL below 70, you don't just give up. The playbook says you add secondary medications like ezetimibe or even those injectable PCSK9 inhibitors.
Right. You are fundamentally altering the liver's ability to produce and process cholesterol. You're trying to starve those plaques of their building blocks.
Okay, so lipids are half the battle. What's the other half?
The other half is blood pressure, which actually presents a much more complex physiological tightrope.
How so?
Well, for most patients with an acute ischemic stroke, specifically those with extracranial atherosclerosis, meaning the blockage is in the neck, the target is aggressively low. We want their blood pressure under 130 over 80.
Okay, that sounds pretty standard. But the sources outline a major, really fascinating exception here.
Yes, the intracranial exception.
Right. If the blockage is intracranial located inside the skull, the optimal blood pressure target is slightly higher. It's less than 140 over 90.
Yeah, which sounds counterintuitive, right?
Totally. My immediate thought is that higher pressure inside the brain sounds super dangerous. But I'm guessing if the pipe is severely narrowed, you actually need a certain amount of physical force just to push the blood past the clog.
You've hit on the exact concept of perfusion. Perfusion is just the steady flow of oxygenated blood soaking into the brain tissue.
Okay.
If you have a severe, say, 70 to 90% blockage deep inside a tiny brain artery, the tissue downstream from that blockage is literally starving.
It needs blood badly.
Exactly. It is entirely dependent on the systemic blood pressure to force blood through that tiny opening or to push it through collateral vessels, which are like the brain's secondary backup pathways.
So if you aggressively drop their blood pressure to standard healthy levels, say 110 over 70, you lose the driving force.
Right.
The blood simply can't make it past the intracranial stenosis.
And then you induce another ischemic event, the flow drops, the tissue dies. You have to keep the pressure just high enough to maintain perfusion, but low enough that you don't exacerbate the systemic atherosclerosis or risk a hemorrhage.
Yeah, that is a precarious balance.
It really is. And of course, these pharmacological interventions have to be paired with non-negotiable lifestyle pillars.
Exercise and diet.
Yeah, moderate physical activity 3 to 5 times a week, a structured diet, and the absolute cessation of smoking.
Quitting smoking is huge.
It's vital. Smoking damages the endothelium so aggressively that it essentially counteracts all the stabilizing effects of the statins.
Okay, so lowering cholesterol, carefully dialing in the blood pressure, changing the diet, that is the long game that stabilizes the plaque over months and years.
Right, that's the foundation.
But in the immediate aftermath of a TIA or a stroke, there is a short-term crisis unfolding at the microscopic level, right? When a plaque ruptures, or when blood flows highly turbulently past a jagged narrowing, it creates this environment that's ripe for immediate clotting.
Yeah, and the body's natural defense mechanisms actually turn against it in this
How
scenario.
does that happen?
Well, platelets are tiny blood cells responsible for clotting. When they detect a damaged vessel wall or when they're subjected to the sheer stress of turbulent blood flow, they become activated.
They get angry.
Basically, yeah. They rush to the site, clump together, and form a thrombus, a clot. Now, in a healthy scenario, like a cut on your finger, this saves your life.
Sure.
But inside a narrowed cerebral artery, that clump either fully occludes the vessel or it breaks off, travels downstream as an embolus, and causes a massive stroke.
So if the body's natural healing response is what's actually creating the deadly clot, it seems like the immediate goal is to temporarily turn off that specific response.
That is the exact mechanism of antiplatelet agents. They make the platelets less sticky, preventing that aggregation.
And the sources detail a pretty massive shift in how these drugs are utilized now,
Yeah.
right? Driven largely by the CHANCE trial and the POINT trial.
Yeah, huge shift. Historically, we might have just given a patient daily aspirin and called it a day.
Right.
But these trials prove the profound benefit of short-term dual antiplatelet therapy, or DIPT.
Using two separate drugs simultaneously. Typically aspirin and clopidogrel, because they block different chemical pathways that tell platelets to clump.
Exactly. You hit the platelets from two different angles.
But the data shows this isn't for everyone, right? It is specifically targeted at patients who have just experienced a high-risk TIA, which is quantified by an ABCD2 score of 4 or higher, or a non-disabling stroke, which is an NIH stroke scale score of 3 or lower.
Right. Those are the patients at the absolute highest risk of an immediate recurrence.
It sounds like deploying a riot squad to deal with an acute, highly localized threat. You have a ruptured, turbulent plaque throwing off microclots, and the dual antiplatelets lock down the area and stop the chaos.
That's a great way to think about it.
But you wouldn't leave a heavily armed riot squad stationed on a street corner permanently, because eventually that level of force starts causing its own set of collateral damage.
Oh, absolutely. And the collateral damage in this case is severe hemorrhage.
Bleeding.
Yeah. Keeping a patient on two potent blood thinners indefinitely significantly increases their risk of a major bleeding event, like a gastrointestinal bleed or even a hemorrhagic stroke in the brain.
So the riot squad must be de-escalated.
They have to be. The risk of those platelet-driven microemboli is highest immediately following the initial stroke. So the duration of DIPT is hyperspecific, and it's dictated entirely by the location and severity of the blockage.
So if the symptomatic plaque is extracranial in the neck, or if it is just a moderate intracranial narrowing, the standard recommendation is just 21 days of dual therapy.
Right, just 3 weeks.
But if the patient has a severe intracranial stenosis, meaning the vessel inside the brain is 70 to 99% blocked, the protocol extends the DAPT to a full 90 days.
Yeah, because the underlying risk of recurrence with a severe intracranial blockage is just so stubbornly high, the window of maximum danger is wider.
So they need the extra protection.
Exactly. The dual therapy needs to remain active for 3 full months to allow the statins and the blood pressure management enough time to stabilize that extremely volatile plaque.
And then what happens after the 21 or 90 days?
Once that window closes, the regimen is de-escalated to just a single antiplatelet agent for long-term maintenance.
Okay, so the biological armor is in place, the LDL is being forced below 70, the blood pressure is dialed in perfectly to maintain perfusion without causing damage,
Yep.
and the antiplatelet riot squad has managed the acute clotting risk. This brings us to the final and perhaps most heavily debated phase of treatment, the physical intervention. Do you go in and open the narrowed artery?
And the answer to that is, well, the geography of the plaque dictates everything.
Location, location, location.
Always. We have to look at the neck entirely separately from the brain. For symptomatic extracranial atherosclerosis, so a blockage in the carotid artery in the neck revascularization is highly beneficial if the narrowing is moderate, between 50 and 69%, or severe, between 70 and 99%.
But there is a very strict golden window for when to perform this surgery, right?
There is.
The sources say it's between 2 days and 2 weeks from the initial event, assuming the patient is neurologically stable, which honestly raises the question of why you wouldn't just do it on day 1.
Yeah, it seems urgent.
If the pipe in the neck is blocked and they just had a stroke, why on earth wait 48 hours?
It comes down to a phenomenon called reperfusion injury.
Okay, what is that?
When brain tissue suffers an ischemic stroke, it's starved of oxygen and becomes incredibly fragile. The blood-brain barrier in that specific area is compromised.
It's weak.
Very weak. If you immediately clear the blockage in the neck on day one, you suddenly blast a high-pressure wave of arterial blood right into that damaged, weakened brain tissue.
Oh, I see.
Yeah, those fragile vessels can rupture, and you end up turning an ischemic stroke into a deadly hemorrhagic stroke.
Wow. So you have to give the brain tissue a minimal window to stabilize. But if you wait longer than 2 weeks, the patient remains exposed to the risk of a second stroke from the lingering plaque.
Exactly. You're racing the clock.
And within that 2 to 14-day window, the surgeon has to choose the method. So there's carotid endarterectomy, which is an open surgery where they physically cut into the artery and scoop the plaque out.
Right, the traditional open surgery.
Versus carotid artery stenting, where a metal mesh tube is threaded through the vascular system to prop the artery open from the inside. How do they choose?
Well, age and anatomy are the primary factors in that decision. The clinical data strongly points to carotid endarterectomy, the open surgery, as the preferred method for patients over 70 years old.
Why is that?
In that older demographic, the periprocedural risks associated with threading a stent all the way up through calcified, aging vessels are notably higher. It's just safer to open the neck directly.
But stenting becomes the favored option when the physical anatomy of the neck makes open surgery too perilous, right?
Yeah.
Like if a patient has had prior radiation therapy for head or neck cancer, that tissue becomes scarred and fibrotic, making it very dangerous to cut through.
Exactly. Or if they have a tracheostomy.
Right. And stenting is also the go-to if the patient has severe cardiopulmonary issues, like recent heart failure, because putting them under general anesthesia for an open neck surgery carries an unacceptable mortality risk.
You nailed it. So in the neck, we generally aim to intervene mechanically if it is safe to do so.
Okay.
But when we move past the neck and look at intracranial stenosis blockages deep inside the brain, the entire paradigm shifts.
This is the big plot twist.
It really is. This is where the Samprais trial completely remapped vascular neurology.
Because this is the trial that defies that basic human intuition of fixing a physical clog with a physical tool.
Right.
The Samprais trial focused on patients with severe intracranial stenosis, 70 to 99% blocked. They compared aggressive medical management against aggressive medical management, plus the placement of a stent.
And the trial actually had to be stopped early.
Which is never a good sign.
No, it's not. It was stopped because the patients receiving the stent were suffering significantly higher 30-day rates of stroke and death compared to the patients who only received the medications.
That is wild. The physical intervention was actively harming them.
Yes.
Which forces us to ask why the plumber snake is deadlier than the clog when we are inside the skull. If stenting works so well in the neck, why does it cause strokes in the brain?
It's all about the structural integrity of the vessels. They are entirely different.
Okay, how so?
Well, the arteries in your neck, like the carotid, are robust. They have thick, muscular layers and surrounding adventitial tissue that provide really strong external support.
They're heavy-duty pipes.
Exactly. Intracranial arteries lack that same level of structural reinforcement. They are thinner, they're more fragile, and they navigate through a highly complex, tortuous path.
So attempting to push a wire, a balloon, and a metal mesh stent deep into those fragile twisting pathways carries an incredibly high periprocedural risk.
Extremely high.
You might accidentally dissect the vessel wall, or, I don't know, the physical action of deploying the stent might dislodge a piece of the brittle plaque, sending it further downstream and causing a massive stroke right there on the table.
Precisely. The mechanical risk vastly outweighs the potential benefit. Because the alternative, that liquid drain cleaner of aggressive medical management we talked about, has become profoundly effective.
Right, the meds are just that good now.
They are. The medical group in the Samprais trial received that 90-day dual antiplatelet regimen, high-intensity statins to force LDL below 70, and incredibly strict blood pressure control to maintain perfusion.
And that combination proved safer and more effective preventing subsequent strokes than trying to force the stent into a fragile brain artery.
It's a phenomenal example of why evidence-based medicine has to overrule our mechanical intuition.
It really is. I mean, we have mapped out a wildly complex, highly choreographed dance today.
We covered a lot of ground.
We did. Treating large artery atherosclerosis requires meticulous, non-invasive imaging to map the exact territory. It demands a biological armor of high-intensity statins and precise blood pressure targeting.
Yep.
It utilizes short-burst dual antiplatelets to suppress those immediate clotting risks. And ultimately, it hinges on the nuanced geographic decision of whether to physically operate on the robust arteries of the neck or to rely entirely on medications for the fragile arteries of the brain.
I mean, every single decision, from the choice of imaging to the exact day a second antiplatelet is stopped, is calculated to tip the scales away from a recurrent stroke.
It really is a masterclass in risk management. But looking at Dr. Wabnitz's conclusion in the source material, there's a fascinating lingering thread here.
Oh, the asymptomatic question.
Yes. Everything we have unpacked today applies to symptomatic patients, people who have already suffered a stroke, or a TIA,
Yeah.
where we know the plaque is unstable and dangerous.
Right.
But this raises a major question about the future of this field. What happens when a patient goes in for, say, a routine ultrasound, feels completely fine, but the doctor discovers a silent, 90% blocked carotid artery in their neck?
The management of asymptomatic carotid stenosis is probably one of the most heavily debated topics in neurology
I
today.
can imagine.
Historically, the instinct was preventative surgery, right? Clear out the silent blockage before it ever has a chance to cause a stroke.
Better safe than sorry.
Exactly. But as our medical therapies, the statins, the antiplatelets, the blood pressure control, as they become so incredibly powerful, the calculus is totally changing.
Because the medications are so effective at stabilizing plaques, that the baseline risk of that silent blockage ever rupturing is dropping dramatically.
Yeah.
Which means the benefit of proactively doing an endarterectomy or placing a stent is shrinking, while the inherent risks of the surgery itself remain exactly the same.
Exactly. Are we exposing completely healthy asymptomatic people to the risks of general anesthesia, vessel damage, and perioperative stroke for a plaque that, if simply managed with high-intensity medication, might remain dormant for the rest of their lives?
It really suggests we might be rapidly approaching an era where, for certain patients, the scalpel and the stent are entirely replaced by the prescription pad and the lifestyle change.
It's a very real possibility.
The diagnostic waters are incredibly complex, but the tools we have to navigate them are getting sharper by the day. And that is definitely something for you to ponder long after this deep dive ends. Thank you for joining us, and we'll catch you on the next one.